Our next speaker is Dr. Lauren Dalvin. We'll be talking about panicking over pigment, management of conjunctival pigmented lesions.
I have no financial disclosures. Thank you so much for having me. We'll talk about pigmented conjunctival lesions today, starting with the clinical features. And we're going to cover nevus, complexion-associated melanosis, primary acquired melanosis, and malignant melanoma. So how common are these lesions? At Mayo, we did a population-based study, and we found the most common pigmented conjunctival tumor was nevus, relatively low frequency of CAM in our predominantly Caucasian population. About a third of pigmented lesions were PAM, and much less common, 1% malignant melanoma. But of course, when you're the tertiary referral center, such as Will's Eye, the landscape changes pretty dramatically, and we have a much higher percentage of melanomas. So this is what we don't want to miss. We'll start with the benign conjunctival nevus. This doesn't tend to make us worry. These are well circumscribed, generally pigmented lesions, but they can be amelanotic, and there's little pseudocysts that often give us a clue these are benign. But these are not pathognomonic. You can see these in lymphangiectasia or mucoepidermoid squame as well. Generally, this is a situation that people get a little more worried about. This is an amelanotic conjunctival nevus in a child, and the reason this tends to cause a little more panic is that up to 75% of these can have some inflammation. So you can actually end up with some pretty beefy vessels in these, and rarely you can get rapid growth, but generally these are going to be benign in kids. In terms of location, nevus is typically on the bulbar conjunctiva, usually close to the limbus, but can be a little farther away. We can also see them in the caruncle or plica. Once we get into fornix, tarsus, or corneal involvement, we really want to worry about melanoma. So lesions such as this, your panic index is going to go up quite a bit. In terms of growth to melanoma, about 1 in 300 risk with nevus. So here's an example of a melanotic nodule of melanoma arising from a nevus. Syndromes you should know about just briefly: Carney complex, autosomal dominant associated with nevus. These need to be sent to cardiology to rule out cardiac myxoma. And dysplastic nevus syndrome patients need to see dermatology because they're also at risk for cutaneous melanomas. So moving on to CAM, this is going to be bilateral, symmetric, generally flat, often at the limbus, but can extend further. These have microfolds that create a cobblestone-like appearance, more common in darker complexion patients. They rarely extend into the tarsus. So symmetric CAM, we don't worry so much about. If we see something asymmetric such as this, we're going to be pretty concerned that we're dealing with a melanoma. Primary acquired melanosis, we worry a little bit more about. We see this in middle-aged patients of lighter complexion generally. It's usually unilateral, asymmetric, and has a flat, peppery appearance. We do not see cysts, cobblestone, or microfold, so that differentiates for us. And there's a higher risk of melanoma associated with these lesions. So when do we worry? I don't think any of us would worry too much about this tiny spot of PAM, but the more clock hours that are involved, the higher risk we have of growth to melanoma. So we're going to worry a little more with this, and we're going to worry quite a bit more if we get to something like this. So we'd probably want to excise this, and if there would be no atypia, then pretty minimal risk of melanoma in the future. But if there's severe atypia, then we're looking at a 21% risk for growth to melanoma with that lesion. So malignant melanoma, this is what we all don't want to miss. And none of us are going to miss this one. These are usually pigmented lesions, but not always. They tend to be elevated. They have feeder and intrinsic vessels, and they have a 25% risk for metastasis at 10 years. So this is a life-threatening disease. We need to involve our medical oncology colleagues for systemic workup. So these generally arise from PAM, but can come from nevus, as we talked about, and can be de novo. And de novo origin is actually associated with worse prognosis, as is tarsal or fornix location, nodular tumor, or orbital involvement. So a couple of clinical reminders: always look in the fornices. This should make you worry for melanoma. Again, you're going to always flip the lid. I'm sure you've heard this before, but melanoma can hide in sneaky places. This is a patient we saw at Mayo who had a history of PAM with severe atypia, and we looked and looked and didn't find any pigment, but if you flip the lid, there's a big nodule of melanoma hiding far up in the fornix. So as Carol Karp talked about, we can use multimodal imaging to help us. So we can use UBM to look for scleral invasion and anterior segment OCT, and that can also be a nice differentiator if we're not sure what type of lesion we might be dealing with. Here's a case of an amelanotic conjunctival nodule, but if we look a little deeper, again, looking in that fornix, we see some pigment. So this is associated with PAM, and that was actually a nodule of amelanotic melanoma. Now, what's this? This is a pigmented lesion. It's a little worrisome, but maybe there's some cysts in there. So is this a nevus or a melanoma? Actually, this was a pigmented squamous cell carcinoma, so not all that is pigmented is melanoma. And this is a reminder that melanoma might have no pigment and it can be really subtle, so we always need to surgically approach every lesion as if it might be a tumor. So how do we treat these? We can treat with surgery, topical therapy, or radiation. So surgery is going to be our go-to for localized lesions. We use a no-touch technique, alcohol keratectomy for the corneal involvement, sclerectomy for deeper involvement, and we want to leave 2 to 4 millimeter margins. We're going to use double freeze-thaw cryotherapy, and our first surgery is the most important, so if you can get it all the first time, please do. No BSS in surgery, no matter how much your trainee might want to keep the cornea clear for you. Do not let them seed tumor. Use clean instruments, clean your instruments with alcohol if you're moving to a new location, and use completely new instruments for your closure. If you're dealing with a melanoma that's greater than 2 millimeters thick, you may want to consider sentinel lymph node biopsy. So wide margins, again, some of this flat peppery pigment might be difficult to see when you get under the operating microscope, so I like to do a drawing in clinic, or we can use inoperative OCT to help guide us for complete excision. Topical therapy, mitomycin C is an alkylating agent. We can use this for PAM. We can use it for melanoma to chemoreduce prior to surgery, or we can wait and let things heal after surgery and follow to prevent recurrence. We're going to use this usually for 7 to 28 days. We, of course, get some side effects of keratoconjunctivitis. We can get limbal stem cell deficiency if we use a lot of this. Interferon alpha-2b, as we heard, is great for squamous cell carcinoma. This is a glycoprotein. There's some talk about using this for melanoma because there are fewer side effects, but I think the effectivity is kind of in question, not good evidence for interferon in melanoma. Plaque radiotherapy we can use after excision to treat deep areas to try to prevent recurrence. You're going to, again, want to let things heal before you put a plaque on. And side effects from radiation, dry eye, and corneal ulcer can occur, but this is usually well tolerated. So a few papers about EBRT or proton beam radiotherapy, generally used for more extensive disease. These are your higher risk patients, and of course, higher dose radiation means more radiation side effects. So this is a case of PAM we managed with surgery and mitomycin C to follow. So we, after excision, had some residual pigment. Mitomycin C really melts that away. Here's a case, is this also PAM potentially? But remember our rule of clock hours, this is going to be 17-fold increased risk of melanoma, so there was indeed all across the cornea and temporally here a focus of melanoma hiding. So we excised that, did some map biopsies and cryotherapy to other areas, and then again we followed with mitomycin C to prevent this from coming back. So really quickly, role of molecular medicine. We now have all these biomarkers, and we're learning how to use them to identify our high-risk patients, to target people for adjuvant therapy, to prevent recurrence and metastasis, and even treat metastasis. And recently, Sarah Lally in the Wills group with Carol Shields discovered NRAS-positive melanoma have greater than 4-fold increased risk for metastatic disease. Targeted medications we have for all of these potential targets now, including checkpoint inhibitors, which we can use to treat extensive melanoma, including orbital involvement without exoneration. So pigmented conjunctival lesions can range from benign to malignant. Localized disease we want to treat with surgery and get it all the first time. We have other things in our pocket if we have extensive disease, and targeted therapies are really on the horizon. Make sure you involve your medical oncologist, and if you're ever in doubt, please ask an expert. Your ocular oncologists are here to help you. Big thank you to my Wills Eye mentors, especially Dr. Carol Shields, who's going to be speaking next, and a thank you to my colleagues on the Mayo Clinic Cornea Service. Thank you.